I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
Our next patient of the day will be a 52-year-old postmenopausal woman with atrial fibrillation, mitral regurgitation, heart failure, and a recent subdural hematoma, who presents with a T2, N2B, ERPR positive, HER2 positive breast cancer after undergoing a right-sided mastectomy with axillary lymph node dissection for an incidentally noted right breast mass on imaging. And the therapeutic question being posed is what adjuvant systemic therapy and or radiation therapy would be recommended. So this particular woman has atrial fibrillation on apixaban, severe mitral regurgitation, well-compensated heart failure, but still with a reduced ejection fraction, most recently by echocardiogram of 40%, and a subdural hematoma requiring craniotomy 6 months prior to the presentation. Her mastectomy pathology demonstrated an invasive ductal carcinoma, which was grade 3, measuring 4.2 centimeters. The surgical margins were negative. There was multifocal lymphovascular invasion apparent, DCIS grade 3 with chemotonecrosis and extensive microcalcifications were noted. And there were 9 of 11 lymph nodes, the largest of which was 16 millimeters with no extracapsular extension. The estrogen receptor, as I mentioned, is positive, progesterone receptor is positive, and HER2 is equivocal by immunohistochemistry, but positive by FISH. She has adequate hematologic parameters and a normal comprehensive metabolic panel. She has undergone curative intent right mastectomy and axillary lymph node dissection, and we are going to elucidate recommendations for radiation therapy, systemic therapy, as well as also endocrine therapy. So maybe we would start out with, first of all, Dr. King, can you just comment, no further role for surgery for this particular patient?
Thank you. No, it appears the surgery has been adequately performed. I would be curious whether a core biopsy was obtained preoperatively. Certainly knowing that she had HER2 positive disease on that core biopsy may have opened up different alternatives for her sequencing of treatment, but mastectomy with axillary lymph node dissection does appear to have been the appropriate treatment at this point in time.
Okay, perfect. Thank you so much. And Dr. Shah, what about the role for radiation therapy?
So in the setting of 9 positive lymph nodes, I would typically consider radiation therapy. Obviously, with her comorbidities, I would make sure, obviously, that she had reasonable performance status to receive therapy. That being said, I think there are some alternatives. I think most patients in the situation would be offered 5 weeks of radiation. I would feel very comfortable offering this patient a 3-week course of radiation or hypofractionated adjuvant radiation to the chest wall and lymph nodes. We have randomized data from China showing this is safe and efficacious. Also, I'd be very mindful of her cardiac dose and cardiac parameters, really trying to use any techniques available to me to reduce the dose to the heart.
Okay, thank you. And Dr. Pegram, do you want to comment about the challenging decision, I think, about systemic adjuvant therapy in the setting of this, cardiac comorbidities, and then also this recent, subdural hematoma requiring neurosurgery?
So This is one of those cases where it's really critical to have close collaboration with a cardiologist. And in particular, in cases like this, I would feel more comfortable, referring the patient to a large academic center that actually has a dedicated cardio-oncology program, because this is a very complex situation. The first thing I would ask my cardiology colleagues is, what is the nature of her, cardiac condition? Is it purely valvular heart disease, which might have the potential for, surgical remedy in the future, et cetera? Or does she have any other underlying predisposing cause to cardiac dysfunction, like cardiovascular disease, for example, and ischemic heart disease that's contributing to the situation? So we need a full understanding of exactly what type of cardiac disease she has, so we can frame what her prognosis is with respect to her cardiac condition, in order to use that as a benchmark to make adjuvant therapy decisions with potentially cardiotoxic agents like HER2 antibodies. The subdural hematoma doesn't really faze me in this case, because it's presumably just due to her ongoing anticoagulation for atrial fibrillation. So I don't think that really weighs into this decision. And then I do note her relatively young age, 52. Were it not for the cardiac problem, she may have an otherwise long life expectancy. And even with valvular heart disease, if she has surgery or even has a transplant in the future, could she then have a long life expectancy if her cancer can be brought under control? Those are the kinds of questions I'd be thinking about to query the cardiologist. That said, she has high-risk disease, 9 positive lymph nodes, a primary greater than 4 centimeters, angiolymphatic invasion in the primary, et cetera, high grade. So she would, in theory, benefit from HER2 targeted therapy, but this would have to be done in close coordination with the cardio-oncologist. Oftentimes, they'll give these patients prophylactic afterload reduction prior to consideration of HER2 antibody-based therapy. But given her high risk of mortality from the breast cancer, I think that there would have to be a discussion about not just a single HER2 antibody therapy in the adjuvant setting, but indeed dual antibody therapy, since adding pertuzumab really doesn't increase cardiac adverse events substantively over single agent trastuzumab. Then that begs the question, what should the chemo backbone be? Obviously, a non-anthracycline regimen would be in order. We could do some de-escalation in terms of the chemotherapy, for example, weekly paclitaxel. The weekly paclitaxel regimen, combination of the dual antibodies, is being used in the neoadjuvant setting now in the Compass HER2 trial, for instance. So, that could be a chemo de-escalation strategy if one wanted to try that. Otherwise, TCHP is a non-cardiotoxic regimen. There's lots of cardiac safety data with that regimen. Clearly, if we were to entertain a non-anthracycline chemo backbone plus dual antibody therapy in this case, we would be doing echoes far more frequently than the every 3-month recommended interval for patients with normal cardiac function going into the adjuvant therapy sequence. So I would imagine the cardiologist would probably want to take a look at her ejection fraction by echocardiography within a month or so, or even after the first cycle, perhaps, if we were going to try empirically some afterload reduction along with dual antibody-based adjuvant therapy. She is ER positive, so if she is able to successfully get through adjuvant chemo with dual antibody-based therapy, then you would layer in endocrine therapy at that juncture, along with continuation of the dual antibodies for a total of 1 year of dual antibody therapy. And then, because of her high risk, because of her primary disease characteristics and bulk of her nodal metastasis, the N2 nodes histopathologically, this begs the question, should she consider extended adjuvant HER2 targeted therapy if, once again, if her heart can tolerate dual antibody therapy for a year, should she get Neratinib in the extended adjuvant setting, particularly because her steroid receptors are positive? That would be a fair question also. The extant cardiac safety data look very clean. Certainly, if she tolerates dual antibody HER2 therapy, it would be very likely that she can tolerate Neratinib also from a cardiac safety point of view. But this is a case where really the cardiologist would have to guide us as to what their comfort level would be to consider HER2 targeted therapy. But because of her high risk of mortality from the cancer, it has to be on the table for discussion in this case.
Absolutely. Okay. Thank you so much, Dr. Pegram. And Dr. Shaw, do you want to comment about the role for adjuvant radiation therapy?
Yes. So, given her 9 lymph node involvement, her LVSI, and her age at 52, I would, as long as her performance status was appropriate, we would use, cardiac sparing techniques to reduce the dose. And I would consider a hypofractionated approach, so 40 gray and 15 fractions as compared to the traditional 50 gray and 25 fractions.
Okay, perfect. So in summary, we would recommend adjuvant therapy, adjuvant systemic therapy with chemotherapy plus dual anti-HER2 therapy, as long as it was felt in coordination with cardio-oncology that that could be tolerated and that the patient was fit for that. There would require very careful monitoring of the patient's left ventricular ejection fraction for the duration of that therapy. Adjuvant radiation therapy, and then ultimately a discussion of extended adjuvant therapy with Neratinib as well, all in coordination with a multidisciplinary team, including cardio-oncology.